simplified.
This is a new technique. Drugs are delivered to the eye systemically and locally. Local treatment options include drops, periocular injections like peribulbar and subtenon injection, and intravitreal injections. And recently to this has been added the suprachoroidal injections. Drugs, when injected intravitreally, overcome the blood-retinal barrier and hence have a greater bioavailability to the retina and choroid. However, they can produce endophthalmitis, cataract, and glaucoma. The suprachoroidal space extends from the ciliary body to the optic nerve. When steroids are injected in the space, they will not produce cataract because they do not come in contact with the lens, and glaucoma because they do not come in contact with the trabecular meshwork. But they are available much more to the retina and choroidal tissues. However, the catch is the use of microneedle, which is depicted here, which is not easily available commercially. The options are a proprietary microneedle microinjector system developed by Clearside Biomedical, which has needle of 900 and 1100 microns length with a bevel of 300 microns. This device, when available, is likely to be expensive, especially in the developing world. A second method is microcatheterization of the suprachoroidal space, which was developed by Medvan but is no longer available. The normal commercially available 30 gauge needle, which has got a bevel of 1200 microns, cannot be used for injecting in the suprachoroidal space if it is directed perpendicular to the sclera, because this would introduce the needle into the vitreous. So is there a way out? Yes, this may be achieved by an oblique entry of the needle into the sclera. So this is the concept that if the needle enters vertically, that is BA, it will traverse shorter distance as compared to when it enters the sclera obliquely. Here it is 30 degrees angle to enter the suprachoroidal space. So this is basically the concept of my new suprachoroidal injection device, in which a 30 gauge needle can be used for injecting drugs in the suprachoroidal space. This device went through various versions of improvement. The present device that is available and is being used has a handle, a base plate which has got an undersurface which is rough to allow its placement on the sclera without any slippage, a needle sleeve which allows the needle to guide through up to the sclera, and a visualization window which allows the bevel direction to be adjusted before it touches the sclera. Now here is an example of the device being used in the goat's eye to test our hypothesis, where a triamcinolone injection has been made. Following this, the sclera is carefully dissected and we discover that triamcinolone is located in the suprachoroidal space. You can see the whitish triamcinolone in the suprachoroidal space. The hypothesis was further tested by injecting methylcellulose and helon in the goat's eye and tested by UBM. There was maximum separation obtained when injected with helon. Our next step was to inject triamcinolone in the human eyes, and an informed consent was taken from the patient. You can see here suprachoroidal injection being made with the device in the human eyes, where triamcinolone is injected, and at the end of injection we can hardly make out where this injection was made. Here is another example of two eyes where the SKITA injection is being done. This is a list of about 10 cases where SKITA has been done. 9 out of these 10 cases responded extremely well with reduction of the macular thickness. So this is a 58 years obese female who is a diabetic and hypertensive. pseudophakic in both eyes, and has got a laser proliferative diabetic retinopathy. She's received 8 injections of Avastin and Lucentis in both eyes, followed by 4 injections in each eye of Ozurdex. And recently, when Ozurdex was not available, she presented with a persistent cystoid macular edema, which was quite significant in both eyes. She underwent suprachoroidal injection of triamcinolone with a dramatic response when she presented on day 14, and now she's been followed for over 70 days and still maintains a flat retina. Similar experience has been obtained in other cases. So suprachoroidal space injections are the future for retinal and choroidal pharmacotherapy. The good part about suprachoroidal injection device which is being presented here is that the recurring cost is only 3 euros, 3 cents for the needle and about 2.5 euros for triamcinolone. Based on the scleral thickness, one could change the angulation at which the needle will hit the sclera and at the point it will enter the sclera. So the suprachoroidal injection device is an all-drug device. It is autoclavable, can inject drugs at varying depths. It can be connected to a mechanized injection system. The recurring cost is minimal. There is no scleral incision required, and it can be used in cases of suprachoroidal buckling. Ladies and gentlemen, I welcome you to a novel and simplified way of injecting drugs in the suprachoroidal space using a hypodermic needle. It is safe, the drug is delivered in the suprachoroidal space consistently, and above all, it is cheap. The window in the needle sleeve allows adjustment of the position of the bevel. We recommend a bevel down entry. If you are in the correct plane, you will not find resistance to injection. Our experience in this pilot study has been encouraging. On your left is persistent DME. 2 weeks after injection, the macula is flat. On your right is post-cataract surgery cystoid macular edema reduced the next day. Indeed, a wow effect. Thank you.
Thanks, sir. But what do you say about the steroid response? I mean, the IOP rise, is it lesser than routine posterior subtenon strike?
So this particular condition, the suprachoroidal space, is bounded anteriorly by the scleral spur and posteriorly by the optic nerve. So the triamcinolone does not come in contact with either the lens epithelium or the trabecular meshwork. Hence, till now this is what 10 eyes, we have done 74 eyes now. There was not a single case of glaucoma, not a single case of cataract. There have been some reports from Chicago where they've shown very minimal triamcinolone they have detected, which may the minuscule level, which may have percolated through the circulation, but they have not been able to detect any drug which can affect the trabecular meshwork. So it is, we have used it in cases of glaucoma, we've injected who have had a retinal problem and the IOP has not risen. And now we have devices available. I have a nomogram which so you can inject it even in myopic eyes with thin sclera. So we have a nomogram where we go inside with the depth, the whole track is 1300 to 1400 micron, and so there's a nomogram based upon the thickness. We normally do HDOCT thickness of the sclera and then decide which device to use.
What would you say about the learning curve?
My co-worker is a retina surgeon who is in Shroff Charity, who did work with me, Dr. Shalini, and she initially had for 2-3 goat size, and then she was able to do it, and then it's possible to do it in cases. It's not a problem. My people who are working with me have also learnt it, so it's possible to inject.
Particular feeling once you enter the suprachoroidal space, or you are still in the sclera?
So the concept is very simple, sir. If you are in the sclera, you will have a resistance, you will not be able to inject. But once you are in the suprachoroidal space, even if the tip of the needle in the suprachoroidal space, it will just flow through. And that is the basic concept behind the whole device. So people are making devices. There's a jugaad of a 23 gauge needle with a 30 gauge needle. So the problem comes up is that these needles can leak from behind, and triamcinolone can come out. People reuse these needles, so there can be infection. Here, everything is disposable. The device is autoclavable.
Thank you.
Thank you, sir.
Thank you, sir.